My name's Jo Handsaker. I am a clinical specialist with Smith & Nephew. My background is nursing, 25 years, A&E by trade, and then I was an acute tissue viability nurse for the latter 14 years of my career. As I'm still a registered nurse, kept my PIN number, but I work as a clinical specialist with Smith & Nephew at the moment. And my job this afternoon is to speak to you about negative pressure in the form of Pico, which is our portable negative pressure, specifically in the use to utilise it with diabetic foot ulcers in the community. But that doesn't mean to say that you can't use Pico anywhere else, and I will mention that throughout the presentation. But we're looking specifically at diabetic foot ulcers. Do we have any podiatrists in the crowd today? I can't see any hands at all. I don't profess to be a diabetic foot ulcer specialist, and as a TVN I always utilised my podiatrist in the care of diabetic foot ulcers, as that's deemed as best practice. But we will look at diabetic feet, we will look at some figures, and then we'll move on to negative pressure and how it can help with their treatment and management. Okay. Any questions at all, please pop your hand up. I'm more than happy for you to ask me as we go along. It's nice to have an interactive audience. It means you're actually still awake and listening to me. And after that, you're more than welcome to come and speak to me later. So without further ado, I will introduce the session. So diabetic foot ulcers are complex. They're chronic wounds usually, which have a major long-term effect on morbidity, mortality, and the quality of life of the patients that are suffering from them. As we all know, they're very challenging to manage, or can be, and they have a considerable impact upon the healthcare economy. So they're very costly to treat and very long term in many cases. So I would like to suggest that adopting a proactive approach to the management can potentially reduce costs and, more importantly, improve the patient outcomes and the quality of those patients' lives who are suffering from these very debilitating wounds. Using negative pressure wound therapy is an example of how this can be achieved. So although I'll be referring to this product as Pico throughout my presentation, we need to remember that it is negative pressure that we're talking about. So this isn't a dressing that I'm discussing with you, this is a therapy. And as much as the Pico, meaning small, looks very cute and sweet, it is actually a pocket rocket. And you need to realise that you need to treat it with the same respect as you would when you were utilising negative pressure. So if you were utilising your larger systems, such as your Renesis or your VAC therapies, you need to remember that this is a therapy and it does carry along with it the same cautions and contraindications, and it will deliver the same powerful therapy that your larger systems will. So that's what I wanted to get across right now, that it is a therapy and we need to remember that. So the burden of diabetic foot ulcers. So Diabetes UK estimates that by 2030 approximately 552 million people worldwide will have diabetes, which is really quite a worrying thought. Approximately 25% of people with diabetes will develop a diabetic foot ulcer during their lifetime, unfortunately. So in the UK, 5 to 7% of people with diabetes currently have or have had a diabetic foot ulcer. And in England, foot complications account for 20% of the total National Health Service spend on diabetic care. So approximately £650 million a year, so £1 in every £150 spent on diabetic treatments. In addition, there are indirect costs to the patient. Negative effects on physical, psychological, social well-being. And what we need to remember is this clientele can be very young patients, so it has a massive impact upon their ability to go to work and fend for themselves and their family. So massive implications, and I've seen it regularly with my younger patients that had perhaps manual jobs. We're always talking about 0-hour contracts now, you'll hear it in the news constantly. So people that don't get to work that day don't get paid, there's no holiday pay and sick pay. So it's really, really pertinent that we deal with these wounds quickly and get these patients back on their feet and back to work when we can. So the impact of the diabetic foot ulcers on our patients. They can cause incredible pain, although I am fully aware of the fact that a lot of our diabetic patients do have a degree of neuropathy, and in actual fact, the fact that they couldn't feel their high heels or their hobnail boots rubbing their foot in the first place has caused the ulcer that they've got. But the ulcers, when they're there, can be painful, and we can also see our patients suffering from ischemic pain, which can be very, very difficult to treat. There can be a restricted mobility attached to these foot ulcers, because a lot of the time we're asking the patients to stay off this foot, and if not stay off it, we're trying to offload the area, offload the ulcer to try and aid the healing. So as I mentioned earlier, if you need to get to work every day and your mobility is restricted and you have a manual job, it's going to be very, very difficult. Sleep disturbance may be caused. The exudate leakage and malodour that these wounds can cause can lead to the patient being very embarrassed, very socially isolated, feel ashamed of the fact that it doesn't smell particularly nice, and like I said, they'll start to withdraw from society sometimes. Massive frustration. I can't begin to imagine how I'd feel if every time I went to get my dressing changed and there'd been no improvement in my wound and I was desperate to get better, or worse still, a deterioration and you saw the look on your clinician's face as if to say, oh goodness me, we're not going in the right trajectory. So they can be extremely frustrating if they're not going forwards and progressing. It can cause lowered self-esteem for our patients, depression, anxiety, and worst case scenario, suicidal thoughts. So they have a huge impact upon our patients, and it's for us as clinicians to try and ensure that we're dealing with these wounds proactively to try and get the best results. So, causes of delayed non-healing diabetic foot ulcers. Now, there are lots and lots of causes, so this is just a snapshot really. So, primary causes. Inadequate offloading. So anybody that knows anything about diabetic foot ulcers will know that it's not just the dressing that will treat this particular wound and make it heal. We really must offload these ulcers, because without offloading you'll have constant mechanical trauma and damage to that wound, and we're really on a hiding to hell with regards to healing. So we need to offload these ulcers correctly, and that will certainly help, along with the dressings or the therapy that we choose to use. If we don't do a correct vascular assessment and we're not aware of how well perfused the foot is, that will have a profound impact. And remember, we can't always replumb that blood supply back in. So if that's the case, if we're struggling to improve the vascular input, then we need to remember in the back of our minds that these wounds are going to be even more difficult to heal without a particularly brilliant blood supply. So they're a difficult wound to heal. If we don't debride the wound bed correctly, and that's a massive part of dealing with diabetic foot ulcers. Firstly, we need to debride the callus that we tend to see developing around the edges of the wound, but we also need to keep that wound bed clean. And wound bed prep, as I'm sure you may have talked about today at some point, or you'll all be fully aware of the term wound bed prep. Preparing your wound bed to move on to heal is a massive part of the wound healing process, and so if we can debride these wounds correctly, keep the callus down around the edges, that will certainly help. And then sometimes we can see tuberculosis within the tissues, and patients that are suffering with neuropathy will have a massive impact upon their ability to heal, and whether they can feel or not when they're walking on it, the pain that's being caused. So secondary causes that may delay wound healing in the diabetic foot is inadequate antibiotic therapy. Now, there are many different takes on this, dependent on which literature you read, but with a diabetic foot and the fact that these patients are, in essence, immunosuppressed to a certain degree, we need to ensure that we're treating these ulcers with the correct antibiotics if they're required. So that's most important, and with the correct dosage as well. Incorrect method of dressings. If we don't dress these wounds correctly, If we don't contain the exudate levels, for example, and we allow the wound to become macerated, that's going to have a massive impact. And of course, some of these patients are on associated drug therapies that will delay wound healing too. So there's a lot going on within these patients that will delay their wound healing, hence compounding the problem of healing these ulcers. There are lots of agents that we may apply to the wounds. Some of these on the slide I'd like to think that we're not seeing much usage of, but in other countries, for example, hydrogen peroxide is still utilised to clean up wound beds. I know it's not common practice within the UK. So there are lots of agents out there that can have a negative impact upon the diabetic foot, and we need to know that. And also systemic drugs that our patients might take, such as corticosteroids, that can have a detrimental impact upon the healing process. So complications and amputation. So the majority, i.e. 60 to 80% of foot ulcers, will heal with the correct treatment and a multidisciplinary team approach, while 10 to 15% will remain active and 5 to 24% will lead to limb amputation within a period of 6 to 18 months after the first evaluation. And then further data goes on to talk about the fact that lower limb amputation, many patients will have a shortened life, and mortality is seen within the next 5 years. So an amputation to these patients can be a grim prospect. So it's really important that we're trying to turn that process around and ensure that these patients don't end up with amputation. So an individual with diabetes and a lower extremity amputation, 55% of these will have a further amputation in less than 3 years. And I'm sure we've all seen that practice, particularly the hospital nurses of you out there, whereby there's sort of a nick and pick type of effect that we used to cause it. So they'd lose a toe, then another, then maybe a 4-foot amputation, and lead on to eventually below knee. So sometimes we may see that occurring. Approximately every 20 seconds, a lower limb is amputated due to diabetes-related complications. That's worldwide, that's not within the UK. Okay, so it is possible to reduce amputation rates by between 49% and 85% through a strategy that combines the most important elements of dealing with diabetic foot ulcers. So as with everything, prevention is better than cure. So we've talked about pressure ulcers massively for the last 8 years or more. It's been massively on the agenda, and prevention has been what we've all been trying to do, because if you don't get a pressure ulcer in the first place, you haven't got to deal with it. Well, it's exactly the same for your diabetic foot. If we can prevent them from occurring, we haven't got that problem to deal with in the first place. So how do we do this? A multidisciplinary treatment of foot ulcers approach is really gold standard. And what we should be encouraging is that anybody, any diabetic with an active diabetic foot ulcer, should be being managed within a correct diabetic foot ulcer clinic. Now, whether that occurs in every area and in every walk of, I don't know. The area that I worked in, we certainly had a walk-in clinic that if we were worried about any of our diabetics that presented with any kind of trauma to the foot, we could walk them into a specific diabetic foot clinic the next day and ensure that they were assessed and seen by podiatrists and clinicians that were geared up to deal with this particular problem. That's gold standard. And being treated in the appropriate organisation. Close monitoring of our high-risk patients as well is absolutely paramount. So diabetics that maybe haven't got an active foot ulcer. So again, going back to the pressure ulcer agenda, our high-risk patients, the patients that we know are at high risk of pressure ulcers, we put interventions in, don't we, to try and prevent the problem. And this is exactly what should be happening with a diabetic foot ulcer. So close monitoring, education of that patient or their carer that are dealing with them to be aware of the fact that they're very high risk of or whatever risk they're at, and the interventions that they should be taking to try and ensure that they don't develop the ulcer in the first place. So yeah, prevention's better than cure, and we need to be guiding our patients into the right places to be looked at and dealt with, and regular screening of the diabetic, regular, at least annually screening of the feet is what is suggested by NICE guidance. The key aim of management is to heal the wound and prevent reoccurrence. So successful treatment involves a holistic approach that includes, so if sadly our patient does develop a diabetic foot ulcer, despite the preventative measures that were put into place, if they do develop an ulcer, then we need to ensure that optimal diabetes control is advocated. We need an effective local wound care approach, so treating the ulcer locally, as in the wound itself. We need to ensure that we're either using the correct treatment or therapy. Infection control is huge and needs to be dealt with immediately. Pressure relieving strategies, as I've mentioned, any podiatrist worth their salt will tell you that offloading is absolutely key, particularly to these wounds that are on the plantar aspect of the foot, and we're going to be putting weight through them constantly. We must offload these ulcers, otherwise it's very, very difficult to heal them. And also, if at all possible, restoring pulsatile blood flow, so improving the blood flow to that foot. All of these elements need to be addressed to optimise the outcomes. So what I'm trying to tell you is, although I'm going to speak to you about Pico in the next slide, Pico is not fairy dust. I'm not standing here and saying to you, if you put Pico on that wound, it's fairy dust, it will heal everything. It's part of the plan. We advocate it as part of the holistic plan of care for these patients. So it's just part of that jigsaw, but we have to ensure that all the other parts of the jigsaw are also dealt with to give this diabetic ulcer the best chance of healing. Are you all with me still? Any questions? Am I making sense? Okay. So, what is negative pressure? Can I just have a quick show of hands? Who has utilised, not necessarily Pico, but who in the room has utilised negative pressure in any way, shape or form for any kind of a wound? So many of you use negative pressure, yeah? Are you all advocates of negative pressure when utilised on the correct patient and the correct kind of a wound? Me personally, being an acute TVN, my wounds were big. They leaked a lot of exudate. They needed closing very quickly. And so it was my bread and butter really. So negative pressure was very dear to me, very close to my heart, and I am a massive advocate for the utilisation of negative pressure. So what is it? It's an active therapy, as I said. It's not a dressing, we are delivering a therapy. It's controlled subatmospheric pressure. So basically we're creating a vacuum within that wound, and it's delivered through a sealed system and applied to open wounds to help promote wound healing. Now what I will say, I've just said to open wounds, we also use it on surgical incisions. So some of you might be in the audience thinking, actually, we pop it on in theatre for our surgical incisions. Yes, we absolutely do, but for the purposes of today, talking about diabetic feet, they tend to be open ulcers that are healing by second intention, and that's where we're focusing today. But yes, we do use Pico to stabilise incision, at-risk incisions, and it does that job very nicely. NICE guidance now talks about utilising negative pressure as a treatment for diabetic foot ulcers. So negative pressure wound therapy has now been included within the diabetic foot problems prevention and management of foot problems in people with diabetes guidance. It actually says consider negative pressure wound therapy after surgical debridement, so you know we're talking about wound bed prep, for diabetic foot ulcers on the advice of the multidisciplinary foot care service. So it is advocated by NICE and it's recognised as a therapy that does do what it says on the tin. So when should we utilise negative pressure on non-healing diabetic foot ulcers? So for the purposes of today and the way that Smith and Nephew market, Pico if you like, We tend to talk about wounds that are of a duration longer than 6 weeks, so a chronic wound. When you read the literature says that a chronic wound is anything between 4 to 6 weeks old because it hasn't followed the normal healing trajectory. So a wound that's been there for 6 weeks plus and that hasn't made any progress within the last 2 weeks of you treating that foot. So you've been using a certain treatment or dressing and it's just not moving forwards within that fortnight, that 2 weeks. So that's where we advocate that you might decide you want to utilise Pico and use this therapy. What I would say to you as a clinician is be proactive. So if you don't have to wait for 6 weeks to decide that this wound's now chronic, see whether it works for a fortnight. As a clinician, I would strongly advocate that we can also be proactive about certain wounds, and as the NICE guidance says, after a surgical debridement, as long as there's not too much bleeding, we can apply this therapy to move that wound forwards. But if you're out there dealing with chronic wounds, you've had no luck after a fortnight of the treatment that you're utilising, think about Pico as a therapy and kick-starting that wound back into the healing trajectory. So essentially, it's a clinical decision, but other factors need to include a comprehensive assessment of your patient, the patient's ability to achieve wound healing, and less palliation of symptoms. So it may be that we have certain wounds out there that are never going to heal, or we know it's going to be very, very, very difficult to heal that wound. And we've all seen patients, sadly, have wounds for years and die with that particular wound because of all of the other contraindications and comorbidities that they have regarding wound healing. Sometimes you may choose to use this therapy as a palliative type of thing to deal with that patient's signs and symptoms, but again, that's a clinical decision. The severity of the wound, we need to look at the severity of the wound to see whether this treatment's appropriate, and failure of the wound to respond to other therapies. So if we use negative pressure on non-healing diabetic foot ulcers to reduce their burden, it's another tool in your toolbox to deal with these wounds. Pico is a single-use, portable negative pressure system which effectively manages low to moderate volumes of exudate. So you need to take that message away from today. Pico, a box of Pico that can last you a week, will manage approximately 300 mils of exudate. There are 2 dressings in a box of Pico. So you get your little pump, which gives you a week's worth of therapy. You get 2 dressings in that box. Each of those dressings will manage approximately 150 mils of exudate. So if your wound is throwing out 500-600 mils of exudate in that week, Pico is probably not your best port of call to begin with because it won't necessarily be cost effective. I'm not saying that clinicians don't choose to do that occasionally. I've seen certain TVNs be happy to get through 2 boxes for the first week or so, because once we reduce the exudate levels and things start to improve, then we soon downscale to 1 box. But in general, we advocate wounds that are throwing out 300 mils or less. More than that, you may want to consider your regular negative pressure therapy. Okay, so examples of appropriate wounds that you can use your negative pressure on, as well as your diabetic foot ulcers or any chronic wound. You can also utilise them on acute wounds, like I say, get proactive if needs be. Traumatic wounds, subacute and dehisced wounds. We have lots of great results with dehiscence of surgical wounds with negative pressure. Partial thickness burns, ulcers such as diabetic foot ulcers or pressure ulcers, flaps and grafts, and surgically closed incision sites, as I mentioned to you. So it's lightweight and it delivers negative pressure of -80 millimetres of mercury. So it's delivering that amount of pressure, which is what you can get from your largest systems. And it will provide, 1 box will provide 7 days worth of therapy. It's clinically proven with more than 5 years of experience. So we have to date 69 clinical posters that have been presented at different conferences, 57 published clinical papers. 11 ongoing randomised control trials and 5 completed randomised control trials. So basically what that slide's telling you is that it's tried, tested, and it does what it says on the tin. So we do have the evidence to back up what I'm standing up and preaching to you today. So how does it work, you may ask? And without getting too technical, I'm going to try and describe it to you. So the anatomy, your diagram to this side, that side, looks at the anatomy of a hard to heal wound. So a chronic wound. What does a chronic wound typically look like? So we may have exudate management problems with a chronic wound because this wound's stuck in the inflammatory process and we're throwing out lots of exudate, and there are lots of cells within that exudate that are now having a detrimental effect upon the wound healing process. These wounds are open for a long time, so they are more at risk of infection. The longer the skin remains open for, the longer we run the risk of sustaining an infection or even that wound developing a mature biofilm. You tend to see those classic rolled edges in a chronic wound, those rolled edges that never look like they're going to epithelialise. That's a classic sign of a chronic wound. We'll have a lot of edema in the surrounding tissues, again because the wound's stuck in the inflammatory process. We may see minimal granulation tissue, and we'll also see unhealthy looking granulation tissue in these chronic wounds that doesn't look nice and pink and granular as it should. So that's another classic sign. There will be poor cell development, so the cells within that wound bed are what we call senescent, and they're not doing what they should. And there can be also a poor vascular supply. Now, in a diabetic foot, you might have a poor vascular supply anyway due to the diabetes and the arterial disease that they may have. But what tends to happen in a chronic wound is there's so much edema in the surrounding tissues that edema squashes, if you like, the capillaries and the surrounding blood vessels and doesn't allow them to deliver as much blood to the wound bed as they should, because they're squashed within this surrounding interstitial fluid. So what does blood deliver to the wound bed? Oxygen and nutrients, absolutely. So we need to improve that blood supply to this wound bed to improve the prospects of healing. So how does negative pressure do? What does negative pressure do? So in a nutshell, beg your pardon, Pico. In a nutshell, it acts as a barrier, so it protects from bacterial invasion. And I'll talk to you about that on the next slide because it shows you the different layers. So what it does with the vacuum that's created, with the suction that's created by this therapy, it removes the surrounding edema from the tissues, and that in turn improves perfusion because it allows the capillaries and the blood vessels to open to their full capacity, to the full diameter, because we've removed that fluid that's squashing this vessel. So then that will increase the blood supply, and in turn that will increase what we call angiogenesis, which are the tiny little capillary buds that grow into the wound bed that are the structure for the granulation tissue that we require to heal this wound. So it promotes lymphatic drainage, and this is essential for optimal wound healing environment. Now, in a surgical wound, we talked about surgical wounds, just to give you an idea in case any of you, that's your speciality and not diabetic foot ulcers. We promote it for surgical incisions. What it'll do in certain wounds is reduce the risk of seroma. So in breast care, we use it a lot. Can help to reduce the risk of seroma, helps reduce the risk of hematoma, and also reduces lateral tension because it splints that wound, if you like. So that's from an acute wound point of view. So down at cellular level, what negative pressure is known to do is it promotes micro deformation, so tissue deformation. So it promotes contraction of the wound edges. So those rolled wound edges that we talked about, it helps the epithelial cells to proliferate and multiply, and it will help with contraction of those wound edges. And research has shown that after 72 hours of negative pressure being in situ, even if you take it away, that contraction that's been caused won't fall back. It's actually permanent, so it does help contraction of your wound edges. and it also, with the macrodeformation, macrodeformation helps with the contraction of the wounds, and microdeformation also promotes rapid granulation tissue because it stretches the cells, encourages proliferation of these cells, and we get better granulation tissue. So that's what it does in a nutshell. We do have a really nice JCN publication actually that talks about negative pressure down at cellular level, but in a very understandable way. So if any of you want to read more around it, on your evaluation form that you've got there, if you don't mind leaving your email address, we can contact you and get different papers and what have you out to you if it's of interest to you. So from a Pico point of view, this is what it looks like. It's multifunctional dressing, has a unique 4-layer design that allows exudate fluid handling and delivers negative pressure. So it has these 4 layers, which are shown here. So we've got the top layer, which is basically it's the same as what we've got on our Relieving, and it's IV 3000. So it protects from bacterial invasion, but it also allows for what we call moisture vapor transmission rate. So it allows for exudate to transpire out of it. So what happens when this Pico collects exudate from the wound bed, approximately 80% of that fluid is transpired out of the dressing, and approximately 20% of it's absorbed into the absorbent layer that we see as the next layer. So super absorbent layer that will trap some of the exudate, approximately 20%. We then have our pioneering airlock layer, which helps to deliver the negative pressure across the whole of the wound bed and stops the structure from collapsing. So that's the airlock layer. And then the bottom layer, the contact layer to the wound bed and to the surrounding tissues, is our silicone layer. So it doesn't cause any trauma on removal or any damage to the skin while sat in situ. So that's Pico in a nutshell. Remember that you can and will need to utilise fillers on some of your wounds. So wounds that are less than 1/2 centimetre in depth, when utilising Pico, don't need a filler, because the Pico will actually collapse into that 1/2 centimetre, and it can still deliver its therapy into the wound bed. Anything greater than 1/2 centimetre, so anything deeper than 1/2 centimetre, or any undermining edges up to 2 centimetres in depth, will require some kind of a filler. So you can either utilise our gauze, so it's exactly the same as the larger negative pressure systems. You can either utilise the gauze filler, the Curlix, or we also do a foam filler as well. Dependent on the viscosity of your exudate will depend on which you choose also. And if you've got awkward undermining edges, you may find it easier to utilise your gauze, because you can just get it into the areas easier sometimes than foam. But you've got both of those fillers at your disposal. We do several different sizes. I'm sure you've all visited the stand throughout the day, but we also utilise, we've got a multi-site size now, which tends to be utilised with a foot area, so with your diabetic foot ulcers, because it can sort of be shaped to the foot, because some of your diabetic foot ulcers can be difficult to, they're in difficult, awkward areas, so this just makes dressing a lot easier. And this slide just discusses when to discontinue negative pressure on diabetic foot ulcers, and my answer to that would be when you feel it's appropriate as a clinician. We advocate 2 to 3 weeks worth of Pico to kickstart a chronic wound back into the healing trajectory. So when we discussed how it does that by delivering more blood to the wound bed, we have papers to show that after utilising 2 to 3 weeks worth of Pico on these chronic hard to heal wounds, it kickstarts the wound back into the healing trajectory, and then the wound will continue to heal after we've ceased to utilise the therapy. You can use it for longer than 3 weeks. Again, it's your clinical judgment. And the size of the wound, the exudate levels, your granulation tissue, how well it's epithelialising, your pain levels, your patient factors, and your clinical experience will all help you to decide when it's time to discontinue that therapy. So, just have a couple of case studies to show you. This is Mr. E, history of type 2 diabetes and peripheral arterial disease. So straight away, we've got a difficult situation here to heal the wound. Amputation of first toe in 2012, presented with a diabetic foot ulcer which had been self-managed for 3 weeks. So we're almost at chronic stage now. Initial assessment showed that the wound was 3 centimetres by 2.2 and a depth of 0.4 centimetres with a 70% slough covering the wound bed. And this dressing was being changed 3 times weekly. So Pico was commenced. After 7 days of Pico, the wound measured 2.7 times 1.7. After 10 days, the wound bed was 70% now granulation tissue, which is starting to look more healthy, and 30% slough. And after 21 days, so 3 weeks of Pico, epithelialisation at the wound edge with lighter removable slough. And at 28 days, so 4 weeks of therapy, it measured 2 centimetres by 1.7. This wound did go on to heal, but we only utilised the Pico for 4 weeks and then used conventional dressings after that. Case study 2, Mr. S, insulin-dependent diabetic, peripheral vascular disease, stage 4 chronic kidney disease. So this patient will struggle to heal. Right fifth metatarsal amputation site, it's not healing, there's a strong odour, large volume of exudate, and when we say large for a diabetic foot ulcer, but it was minimal enough to utilise Pico obviously, so less than 300 mils a week. Initial assessment 4 centimetres by 1.5, wound bed 100% adherent slough. So after 4 days, we're down to 3.2 and just under a centimetre. Wound bed's sloughy and there's still purulent exudate. So they decided to utilise Acticoat Flex 3, which is the antimicrobial that we advocate as a company to utilise underneath our negative pressure if it is required because you feel that there's either a heavy colonisation or the wound bed's infected. So after 7 days, the ulcer now measures 2.5 centimetres by just over 0.5 centimetre. There's less odour, less exudate, and we've now got 100% granulation tissue. Pico was discontinued at 18 days, and this wound went on to heal at 18 weeks. But as you can see, there was a rapid reduction in size, problems for the patient, and we saved the foot basically because this wound could have easily gone on to create further amputation. So in summary, and I've managed to do it on time, diabetic foot ulcers are a burden to the healthcare system and of course to the patient that's suffering from it. Intervening with negative pressure can help to reduce this burden, and just remember, doing the same thing week after week after week doesn't change outcomes. Sometimes we need to start thinking outside the box and looking at different ways of healing our wounds. By using dressing innovation to maximise a product's potential, not only does this benefit the patient, but can benefit you by freeing up your time. And remember that NICE guidelines do recommend the use of negative pressure on these diabetic feet. So what is the cost of not doing anything for you and your patients is the question really. So any questions from you guys to me? No? Thank you very much for listening. Enjoy the rest of the afternoon.